Welcome everyone to our 14th meeting of our Fabry Family Community virtual meeting series. And tonight we have talk about eye involvement in Fabry disease by Dr. Langis Michaud. And I'll tell you a little bit about him. And then after I do that, then we don't have my trusty co-host on with us this evening, but we'll manage. So I'll tell you a little bit about Dr. Michaud, and then he'll speak and then be available for questions. So as you think of questions, please enter them in the chat box as we usually do. And just a reminder, if you need to use the closed captions feature at the bottom of your screen, you'll see a CC and a live transcript button. You can select that and you can read along as well if you have any hearing loss or any problems with hearing what's happening. So with that, Dr. Langis Michaud graduated from the School of Optometry at Montreal in 1986. And he also obtained a master's degree in physiological optics in 1998. He received a diploma in public administration from the National School of Public Administration in 2006. I believe that's in Quebec, yes?
Yeah, in Quebec,
yeah. And he is a full professor and practices at the University of Montreal for 20 years, since 2001. And as the chief of the contact lens department since June 2020, and the dean of the school. So we have a very experienced person on to present to us tonight. He is a fellow of the American Academy of Optometry, the British Contact Lens Association, the Scleral Lens Education Society, and the European Academy of Optometry. Dr. Michaud's main interests are, and I don't even know if I can pronounce these all, but I'll give it a try. He has several main interests, and he's also interested in ocular manifestations of Fabry disease, of course. So that's why he's here with us today. He's published numerous articles in peer-reviewed journals and publications, and is author in many books, book chapters, and has acted as an editor in France and the United States. So we are welcome to have someone with such great expertise talk with us about eye involvement in Fabry disease. You can share your screen whenever you're ready, Dr. Michaud.
And I'm doing that right away. So can you see my slides?
Yes.
Okay, thank you very much. Thank you for having me tonight. It's a pleasure to talk about Fabry. It's probably one of my biggest passion in optometry. I came to Fabry by accident, but from day one, I'm really interested in the disease, and certainly to help people affected by the disease. To this point, I examined and followed over than 50 patients with Fabry. So I think that I'm the Canadian optometrist who saw the most Fabry patients in his practice. So we will present the findings of what we covered over the years, and we will. I'll be more than happy to answer to your questions. Here are my disclosures. I'm receiving research funds from Sanofi Genzyme Canada. I received that in the past, and obviously this is the disclaimer from the company. So just to remember, probably better than me what is Fabry, because most of you are affected with that disease, not all. But just to make sure that everybody on the same page, Fabry is a lysosomal storage disorder. So what that means, a lysosome is a part of our cells. Every cell has a lysosome. It's a kind of a very teeny area in the cell, responsible to digest big molecules. So when you eat, like I say, in your stomach, the digestion happens, and after that goes in the blood. The products are going in the blood, and from the blood going to the cell. So these are macromolecules, or these nutriments coming from the blood, enter into the cell, and they have to be digested over there as well. And the lysosome is responsible for that, and it does that because the lysosome produces an enzyme. An enzyme is kind of a chemical product that just cut the macromolecule, the big chunk, in smaller particles to make that particle available for the body to be to help to function. And so lysosomal storage disorder, that means that the lysosome is one of the lysosome or the lysosome in the body are not working well. One of the enzyme that is supposed to be produced is missing or is partly produced, meaning that there's not there, it's not at the level it's supposed to be in the body. So in the case of Fabry, so this is an example, a drawing. So habitually a normal lysosome will produce this enzyme and will just, cut the big molecule in small particles and exit the cells and nourish the body. When you have this deficiency, when the enzyme is missing, the substrate or the big molecule accumulates within the cell because it cannot be digested. And so the cells accumulate those debris, and obviously, because there's no space for that, the cell will die at a given point because there's too much thing in the cell, cannot function anymore. And cell by cell, then after that, it's an organ that will not function properly. And then after that, it will be a system. And then after that, it will be the entire body. So we have 40 enzymes produced in our body. So whenever one of these enzymes is missing, you have a disease. So lysosomal storage disorders is a group of 40 or 40-ish diseases coming from the fact that something is missing in their body and they accumulate substrate. They are all hereditary and progressive in nature. That means that you inherit these diseases from your parents or your grandparents, and some are transmitted from carriers, meaning that the parent cannot be symptomatic, but they can transmit the disease. But in the case of Fabry, it's not the case. There's not such a thing as a carrier. You have or you don't have Fabry. It's an X-linked disease, meaning that it's really linked to the X chromosome. So you are affected or you're not affected. You cannot carry Fabry. You are a Fabry patient or you're not. Period. So they are hereditary progressive. Why? Because if there's no treatment, if there's no enzyme therapy to replace the enzyme that is missing, the substrate will continue to accumulate and the disease will continue to evolve. Obviously, if the disease is evolving, it will lead to irreversible damage to organs, and they can become life-threatening sooner than later in some cases. So it's very important to identify and screen those diseases very early in the process, because most of them nowadays have treatments or options for patients, which was not the case many years ago. In the case of Fabry, the enzyme replacement is there just for 20 years. It started in 2000. Before 2000, there was no treatment for Fabry, and except that you have a cardiac involvement, you can have a cardiac medication. But as for Fabry, to replace the enzyme and to cease to accumulate the substrate in the body, there was no option. But since 2000, there's an option as well. So in the case specifically of Fabry, what is missing is the alpha galactosidase A, or alpha-gal, we call it, and it leads to the accumulation of JB3 in the blood vessels. Complicated words, right? But just to make things simple, if you look at the blood vessel at the bottom of the slide here, right, and you will see a blood vessel, and you will see the yellow deposits inside of the blood vessels. So it's in the walls of the blood vessels. Everybody knows about cholesterol, right? If you eat, too much lipids or too much glucids, you will accumulate cholesterol, and cholesterol will accumulate within the blood vessels. So it will block the vessel because, those big lipid deposits will accumulate and the blood cannot really flow on that blood vessels. Here, it's not in the blood, it's in the wall, meaning in the envelope of the blood vessel that the substrate will accumulate. But it's at the end, it's exactly the same thing, because if the envelope accumulate and accumulate and accumulate and accumulate, so my blood vessels go from here, 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 and it's reduced in size and diameter. So it will impact the blood flow, and it will impact also the delivery of the metabolites, or what the body produce to nourish the cells. If my wall is too thick, let's say that you have sugar in your blood and sugar needs to nourish cells, the sugar will not be able to travel at the same speed if the wall of the blood vessels become thicker, right? So the cell can miss some sugar, it can miss some oxygen, can miss some elements, and this is why these cells may also be altered because of that. So important to understand that these blood vessels will accumulate these deposits, and because of the blood cannot really flow normally, it will create pressure in the blood vessel, and this is why Fabry patient will develop vessels tortuosities, because the flow in the blood vessels is not normal anymore, and the blood has difficulty to go through the blood vessel. So it creates some pressure, and if you put too much water pressure in your hose, your garden hose, obviously the hose will just develop tortuosities as well. Same thing in our body. It will these blood vessels will never collapse. You will not have hemorrhage out of that, but you will have tortuosities and microaneurysm. They are coming from that because substrates accumulate in these blood vessels, and this is a kind of a bump in the blood vessels, the deposit, and the blood just fill in that bump, and you develop these blood red spots in your skin, because these are microaneurysms. These are signs that something is accumulating in these blood vessels. So we see here in the I'll just take a laser. So we see here one of the blood vessels of the eye, which is tortuous. Visually, that blood vessel is straight, but because of the accumulation of the substrate in that blood vessels, it's very, very teeny. It's less diameter, reduced diameter compared. It's smaller than a hair. So this blood vessel, there's teeny blood over there, but still, the pressure is higher, so it developed these tortuosities. This is what we see, clinically speaking, and this is what can we have as on one of the first signs to identify Fabry. In the case of the ocular involvement, research showed that it may happen even in utero before birth. We can track down some signs. It's rare, but we can track down some signs and symptoms, in fetus before birth. Habitually, we will see, ocularly speaking, the first sign, the first manifestations of Fabry around the age of 4 to 6 years old. It's very young, right? But still, you will have pigments accumulation in the cornea. We call that cornea verticulata, which is the first sign to appear. The onset is very, very early in life, and 4 6 years. And these kids will not follow the normal curve of growth. Their weight is under the curve, and their height is also under the curve. The puberty is also delayed, and sexual dysfunctions may occur. So it's obviously, generally speaking, And one of the things I learned over the years with Fabry patients is I cannot make averages or means with Fabry patients. Every patient is different. Every patient is different, and even one eye is not comparable to the other one. There's not a mirror effect. I never have the similar findings on both eyes. So it's all dependent on where the substrates accumulate. The debris in the cells, where they accumulates, it will give you the particular symptoms you have. Some will develop more symptoms here, some will develop more symptoms there. Habitually, men are more affected than women. Why? Because, as I said, it's an X-linked disorder, meaning that the chromosome X is defective. So this is why we are missing an enzyme. As a man, I have a chromosome in X form and a chromosome in a Y form. So the Y is normal, but the X is abnormal, but I just one X. So I have the disease, and it's full spectrum. Women have 2 X's. This is their nature. So they have 1 X that can be, affected and abnormal. The other one may be obviously normal. So because one is normal and one is abnormal, the symptoms habitually are less severe. But I saw women as sick and as affected as men, but I saw a lot of women who were not really affected, very, very few symptoms. They got Fabry, they have Fabry, they are Fabry patients, but they have less symptoms. They have other symptoms compared to men. It's not the same. For example, most of the women suffer from high fatigue. They have no energy by noon or by midday because of this accumulation in the blood vessels, and the oxygen and the sugar and everything cannot really go to nourish the body elsewhere. It goes, but at a reduced rate. So they have less energy, and nobody understands why. And they will say, "Oh, okay, you're depressed." No, you're not depressed. You have Fabry and you have fatigue coming from Fabry. Women have more cardiac issues compared to men. Men are affected cardiac, and certainly Mr. Walter is a true example of that. But habitually we see a little bit more cardiac involvement in women, but the renal function is more severe in men. So depending on where the substrate accumulate, then symptoms will be different. So ocular manifestations occurs very early in life. The first one here to show up is in the eye. The second one is the neurological involvement very soon. We're in childhood and adolescence here, very, very early in life. Acroparesthesia, you know what this means. Twingling in the hands and the feet. And it lasts for several hours. I don't have February, but if I'm going outside, I'm in Montreal. Mid-January, Montreal, it's minus 20 Celsius, minus 30 Celsius, very cold. So if I'm going bare hand in my outdoor in Montreal and I stay there for 10 minutes at minus 20, I will freeze. My fingers will freeze. And when I just come back inside, I will feel that twinkling effect, but it won't last more than 5-10 minutes, right? But in the case of Fabry, it's 1 hour, 2 hours, and it's very, very painful, very painful. But nothing really is obvious. That the kid may complain about that. Hey, Dad, hey, Mom, it's something strange in my hands and my fingers or my feet. Look at that. No redness, no blood vessels, no sign, no, nothing abnormal. Okay, go play. And it's like that, forever. So nobody really believe them when they complain about something because it's not really visible. And after that, it will be hypohydro, sweat. When you exercise as a normal person, you are sweating. Why? Because it cools the body. Then you can do exercise and you can do your physical work. When you do not sweat, you cannot sustain for a long time a physical effort. So as a young kid or adolescent, you cannot play baseball, you cannot play football for a long time, or you cannot run as other kids are running, because you develop that fatigue and your body really can't support that type of effort because sweating is not present. Heat and cold intolerance, again, when exposed to heat or cold, these crises, these pain, these symptoms will just show up. Later on, adolescence, early adulthood, the gastrointestinal manifestations will come. It's most of the time confounded with Crohn's disease, for example, or some other gastrointestinal complication. Not really related to Fabry for most of the docs in the field. Diarrhea is frequent, and I had a 5-year-old girl referred to me with suspicion of Fabry, and obviously she had signs in ocular environment, and she had verticulitis and the other things, and Dr. Bichet, my partner, tested her, and she was confirmed as a Fabry patient. Her only symptom was that she got diarrhea once in a while, every 3 months, middle of the night for 2-3 hours. Boom, crisis, diarrhea, and it was over the next morning. So it happens to every kid around the world, right? And parents were just, okay, it's probably she ate something that she didn't tolerate or something like that, and that was end of the story for them. You know, she had really no symptoms other than that, but she was confirmed, and later on she was also followed for other signs, and she's now, you know, around 10 or 12. Angiokeratomas, the little teeny blood spots on the surface of the skin, will develop later on, and the renal involvement, renal dysfunction, proteinuria, creatinine level is very high, and if it's severe enough, we'll obviously ask for dialysis. You know, later on, you know, late adolescence, young adulthood, especially for men here. After that, it will be hearing loss, tinnitus, attacks and strokes, cardiac manifestations, cerebrovascular manifestation at the end of life, if we do nothing, if there was no treatment. So come back to the ocular manifestations, the first ones to show up. This is what we see. This is an eye, obviously. This is the iris, the pigmentation, the colored portion of the eye. This is the pupil, the black hole in the middle of our eye. And the cornea, the gray part here is the cornea. Cornea is kind of the mirror, transparent habitually in front of the eye. But if you see well here, you see that our grayish lines, or you see this spot of pigments here, you see this spot of pigments here. We call that cornea verticillata. This is accumulation of substrates, pigments, in one of the layers of that cornea. Cornea is made of 5 different layers, but in the middle of the superior cornea, this is where the substrate accumulates. And it develops just like if you look at a hurricane from the space, you see a vortex. And this is a vortex inferior of the cornea here, and from this vortex the pigments are just spreading in all the surface. And again, both eyes are completely different. One eye can be highly affected, as we see here, with a lot of pigments, and the other one very few pigments at all. So it doesn't disturb the vision. These pigments do not alter the vision. These Fabry patients are habitually like normal patients as for vision. 40 are myopic, normal vision 20/20, 6/6 for most of the patients. The only thing that we really find different is the visual field. Visual field is the extent of what you see when you look in front of you. If I stretch my arms like this, you know, I see my two hands, you know, moving on those parts, because I have a full visual field here if I look straight there. But there's a teeny spot in that visual field. We don't see that because we have 2 eyes looking at that. But when the eye is made of, obviously, the retina, the cornea, and all that stuff, but the optic nerve just at the back of the eye going to the brain to see, because we see here, really, the visual brain is here behind the skull. So from here to there, just nerves transmitting the vision. So where the optic nerve is connecting with the eye, we call that the blind spot. Okay, because if I follow a light, you know, because there's no cell in that particular area of the eye, I will not see the light. I will lose. Say, if I look at just one eye, I have a very teeny spot where I have no vision at all. Not really a problem, because the other eye is seeing that spot, right? When we have 2 eyes working together, you know, we have no hole in our visual field because both eyes compensate each other. But in the case of Fabry, there's that blind spot is a little bit larger compared to normal. And we see here another example of cornea verticillata. You see the beautiful vortex here, and you see the brownish pigments and the haze of the cornea, loss of transparency. Again, nothing to do with vision. It doesn't create the light sensitivity. It's just there as a sign. Fabry shows up like this. And this is why, as optometrists, and I traveled the country, I traveled the US many times. In fact, next week, Saturday, I will give a lecture on Fabry to American optometrists in a big congress, just to raise awareness about the disease, because slit lamp, we do slit lamp on every patient we see. I see probably 4,000 patients per year. I'm doing a slit lamp exam, a biomicroscope. I'm looking at the eye with a microscope on every of these patients during all year. So what I say to my colleagues is, we can miss sometimes a very few pigments here and there. You cannot miss this one. But when I graduated 30 years ago, there was no cure, no treatment. There was no research on Fabry, period. So we saw that in pathology courses, okay, if you see pigments, it may be Fabry, period, because there was nothing to do really as an eye. And there was no real screening, nothing like that. Now we have treatment. Now it's important to screen them. And if I have, a 10-year-old boy showing in my exam room and I see that type of pigment, and no one in the family knows that Fabry exists, I will refer him to be screened, because it's so obvious for me that it's Fabry. And most of the time that patient will be confirmed, and for every patient in one family, we'll find 8 to 10 relatives in the same family, cousins or uncles or grandparents, that are also affected by the disease. So very important, because we can now follow and treat those patients, and to help them at least to put the name of the symptoms they have, and to let know the family doctor and the neurologist and the cardiologist that, okay, now we know what is going on. This is Fabry, and the treatment is completely different. The management of the patient is completely different from there. So corneal reticulata, again, we know that these deposits are going in the subepithelial layer. So one of the layer of the cornea, and you see again here a good example, the vortex. You see the shape of the vortex here, and the vertical haze and pigment accumulation all over the place. This is a beautiful example of what we see under the microscope. Look at this one here. Very, very few pigments. One black brownish line here, few here, just like a cat mustache, and that's it. Here it's grayish pigment. It's not brownish, it's grayish pigment. Here just haze, no pigments at all, just a loss of corneal transparency. Here a patch of pigmentation. So every patient is different and every manifestation is different, but they are all Fabry, and this is what brings us a high suspicion of the disease. Again, a few examples. This one is not similar to this one, not similar to this one, not similar to this one. And again, this is very, very obvious for most optometrists, trained optometrists or ophthalmologists who see corneas, but you have to look at that. And I saw patients coming, let's say that, I had the girl, 16 years old with Fabry. I asked to see the parents, the dad and the mom, and both were in good shape. And dad was over 50 years old, working in construction. He built houses, strong man, healthy man. So when he entered the room, I said, okay, probably not him, because at 50 years old, not diagnosed, chances to have Fabry is very, very minimal. So the mom, the lady, looked at me suspiciously, said, oh, no, it's not me, certainly not, because, you know what, I have these glasses, I'm very highly myope. This is not my first eye exam. And nobody told me that I have pigments in my eyes and that can have that disease. And I examined her, and she got pigments. They were very teeny, not so obvious. I agree. I confess, but they were there. So this is what I'm telling to my fellow practitioners and my colleagues. Look at the slit lamp. Look carefully, because even if it's a Friday afternoon at 4 p.m., you're ready to start your weekend. It's very, very important, because if you screen one, you'll find more than one, and you will help that family to go over that disease and to be treated, and to at least to be handled properly. Again, here, two brothers. One more obvious, one more symptomatic as well. And the other one, two eyes, again, completely different. Very, very few pigments on one eye, and more here on this one. Same thing here, verticulata again, beautiful manifestation. What is intriguing is that the same pigmentation can occur from medication. If you take amiodarone for cardiac, if you take chloroquine, or hydrochloroquine. We we had this drug promoted as one of the first treatment for the COVID. It was not effective, obviously, and may create a lot of problems in the body. But that particular hydrochloroquine can accumulate pigment in the cornea, very similar to Fabry. But the difference is two differences. First, when I see pigments, the first thing I look at is the list of medication of the patient. If I don't see one of those medication, okay, may not be the case for this pigmentation, and my suspicion for Fabry is just going higher. The second thing is that in the case of those medications, the pigments will accumulate symmetrically. Both eyes will exactly be the same, will look the same. It's never the case in Fabry. Never, never, never. So that, for me, it's the differential diagnosis. If two eyes are exactly the same, they are mirror one of each other, they're exactly the same, it's probably related to medication and not to the disease itself. The second thing that later on in life, around 30, 35 years old, that patients will develop is, we call that Fabry's cataracts. They are not similar to the regular cataract that will affect people over 65, 70, 75, the natural cataract that our eyes develop. What is a cataract? You see that white part here, we are in the middle of the eye now, is the lens, the natural lens of the eye. We call that the crystalline lens. And habitually it's very transparent, just like a window. And that structure just helps to concentrate the light rays to help us to see. This is how we focus at near, how we focus at distance. We see clearly because this lens is acting just like the lens of a camera. But with Fabry, it will accumulate deposits again in the lens, and the lens will lose its transparency in two different areas. A lens is just, if you cut an onion in half and you look from the side, you will have the skin of the onion and you'll have the inside, right? With things with the structure well known of an onion with rings all over the place, and the crystalline lens is exactly the same, but just between the skin and the body of the onion, just between the envelope of the crystalline lens and its body, then this is where the accumulation will occur, and we will see the cataract just over there. So you see accumulation here, it's whitish, this is transparent, and this is whitish again. So it's just below the skin and between the skin and the body of the crystalline lens. Very, very typical there. I don't know any other type of cataracts that is similar to this one. So when I see that, my suspicion for Fabry again is high. And we have here the posterior surface, the deposits on the back of the lens, more granular, more grayish in nature, and this can create a lot of light sensitivity. Fabry patients are highly light sensitive from the age of 20, 25, 30 years old, obviously, and later on. Why? Not because of the pigments in the cornea, because of this, because of the loss of transparency due to the accumulation of deposits in the crystalline lens. The third sign is the tortuosities of the blood vessels. I already mentioned that. The white part of the eye is habitually well nourished with blood vessels, and it's easily seen as tortuosities. And you may have also accumulation here, the what we call the microaneurysm. I will have more than that to explain this. Tortuosities here, two sisters, one more symptomatic than the other one. There's a link between ocular manifestations and the body or systemic symptoms. The higher the symptoms of a Fabry patient are, more signs will be seen on the eye. Habitually, it's an equilibrium. So this one was less affected, obviously less tortuosities. This one, the blood vessels are more enlarged, tortuosities is more present, and with no surprise, she is more symptomatic. This is a microaneurysm. A microaneurysm, if you remember, around the blood vessels, in the envelope of the blood vessels, the substrate accumulate, and because of the pressure is high, because the blood vessel is reduced, it if at any point that blood vessel is weakened and for some reason, the pressure will generate a kind of a bulging of that blood vessels, and it accumulates blood. It becomes a blood spot. Coming from the blood vessel and visible from the surface of the eye, surface of the skin. So we call that microaneurysm, and we see here one, and we see a larger one here. We see multiple teeny microaneurysm here. Again, it just raising the suspicion for Fabry. I have verticulata, I have cataracts, Fabry cataracts, I have vessel tortuosis, I have, these microaneurysm, boom, done. It's a Fabry patient, and obviously, again, as I said, the higher the symptoms, the patient will have the higher the ocular manifestations. To the contrary, if I see a lot of ocular manifestation in a patient, I expect, if I ask, that the patient will tell me that his symptoms are very high. This is one article I published about Fabry. This is a new finding. The microaneurysm were never reported before my study on the external part of the upper lid, and I saw them also on the bottom eyelid, just very below the eyelid here, on just the inner part of the lid here. We call that the canthus. So we can find them everywhere. It's where the substrate or the deposits accumulate and where the blood vessel will become enlarged. So it tells us that there are deposits in the blood vessels. The location of that accumulation doesn't tell us anything. It's very, very random, and it's can be everywhere. Same thing, the blood vessels, because of the pressure, will become enlarged and will develop those microaneurysm as well. And there's a correspondence and correlation between the blood vessels and the microaneurysm on the external superior lid and the conjunctiva, the white part of the eye. If I find a microaneurysm on the white part, I will find a microaneurysm of the superior area. One of my colleagues in the US, Dr. Sivley, she's working in Birmingham College of Optometry over there. She published this article, very interesting. She's out of the US, right? And she found that Fabry patients, she's also following a cohort of Fabry patients, and she found a lot of what we call that lymphangiectasia. That means that it just like accumulation of water or just like a blister on the surface of the white part of the eye. Personally, I never saw that much in Fabry patients, probably regulated by climate. If you are exposed to sun and drier environment, you develop more dry eyes, right? So this is why probably these symptoms were reported, but it may happen as well. If we go on the back of the eye, so we went from the cornea, which is on the surface, and then we move a little bit inside, which is the crystalline lens, and then we move to the posterior, the back of the eye, which is the retina. The orange thing that you see there is the retina. It's a kind of is the screen helping us to see. It's millions of nerves that will absorb the light and will transform the light we see and we are exposed to in the environment as electric signals. And these electric signals go in the brain here, and the brain interpret those signals, and then we see, oh, this is a mug, this is an apple, this is a cat, this is a dog. Why? Because these pixels, just like pixels in a TV, millions of pixels just fire in that virtual brain, and then we can we can see. But this this retina, this tissue that is essential for our vision, is well nourished with blood, because it takes a lot of energy to function. It's one of the area in our whole body where there are more blood vessels per square inches compared to anywhere else. But the blood vessels are very teeny, so again very susceptible to substrate accumulation. And if you look clearly here on the right inside of your screen, the blood vessels of nourishing the retina here are tortuous, again, as they are tortuous in the white part of the eye. And inside of the eye, this is the only place where we can't see blood vessels without cutting or without doing surgery. So this is why an optometrist can diagnose or see signs of diabetes, hypertension, blood hypertension, cholesterol. We see that because we have access, just looking at the back of the eye, to the blood vessels. And these are several manifestations of these tortuosities, even one big artery here that was collapsed. We don't see any blood vessels coming out of this artery here because of accumulation of this pigmentation. So in general, if you have this verticulata, if you have microaneurysm, vessels, tortuosities, and you have also microaneurysm and tortuosities on the external upper lid and in the back of the eye, you can assume very fairly that you have a Fabry patient in front of you. We know that these signs will evolve over time if we do nothing. I did a research on the Fabry cohort I followed for now over 7-8 years for some of them, and treated or not treated with enzyme therapy or not, I saw that the ocular signs, ocular manifestations, the pigments are still accumulating in the system. So that means that the symptoms and the signs that the signs that I saw 5 or 6 or 7 years ago are now worse compared to they were at baseline. So pigments are still accumulating despite the fact that enzyme treatment is given. That doesn't mean that enzyme treatment is not useful. It's highly useful, very useful for renal function, for cardiac manifestations. It helps a lot. And at least you accumulate less pigments compared. But these areas in the eye, again, very small blood vessels. So it's easy to accumulate something in there but in major systems, it helped a lot, and it helped to restore quality of life. And probably a new hope. There's a new medication coming in the market for the last years, 2-3 years in Canada at least. I don't know if it's available in the US, but we have megalostat now. It's a chaperone. It's kind of a pill that helps it's for certain Fabry patients only. We have to have a specific mutation or specific genetic code to have this medication effective for, and this medication helped the body to interpret the X chromosome and to produce enzyme again. So we call that a chaperone because it takes a chaperone for the body to, produce this enzyme again. It's not injection; it's a pill that you take, and then the body restart to produce the enzyme, at least in some patients. And I saw this patient, and surprisingly, sorry, after 8 years, first time I saw her, it was 2012, and I saw her back in 2020 after many other visits, but she began to took this megalostat a few months before her last visit in 2020, and her pigmentation on the cornea just disappeared. So I never saw that before. Never saw that with enzyme treatment, regular enzyme treatment, injections, but with that medication, the pigments are gone. So that means that not only they do not accumulate anymore, but maybe at least on the eye, the pigments that were accumulated are now digested and they are not present anymore. And you see that the tortuosity is less severe. Everything is less severe as symptoms, as signs on the eye. So this is a quick overview of what Fabry brings to the eye. Again, no real functional problem except for the cataract that brings light sensitivity, and we will recommend surgery very sooner than later because of those symptoms, but it's regular surgery as for any other cataract patient though. But otherwise, these ocular manifestations are there just for one thing, to open our eyes to the Fabry disease, and for us as optometrists and ophthalmologists to be able to screen these patients and to make sure that, you know, we refer patients in the proper hand, the right doctor to have the right place. So,
Brenda, can you hear me? This is Jerry.
yes.
You can. Okay. I'm having a little bit of technical difficulty on my end again, so I don't have all of the features on my screen, so I didn't know whether I was muted or unmuted. But anyway, thank you for a great presentation. I have a question about, I can't use, my computer won't allow me to use the chat box either. So I have a question about amaurosis fugax. And I was diagnosed with amaurosis fugax once, and it was believed that it was also because of Fabry, because of the occluded vessel. Does that make sense?
Yes and no. Amaurosis fugax is occlusion of blood vessel, right? But not related to Fabry. It's more kind of cardiovascular issue more than anything else.
Okay. The physician wasn't very familiar with Fabry,
Okay,
but
so because it may be confusing. Yeah, it may be confusing because both are vessel obstruction, but in that case, it's obstruction coming from the inside of the blood vessels, not the envelope. As I said, with Fabry, you will accumulate debris in the walls of the blood vessels, not inside of the blood vessels, and they will never collapse entirely. So we will never have a complete occlusion of the blood vessels because of Fabry. So this is why there's no hemorrhage, but you can have
so the occlusion was
stroke though. So that's another thing.
The occlusion was more similar to cholesterol rather than
yes,
Fabry.
yes, yes. For amaurosis fugax, yes, because it's not recognized as a key symptom for Fabry.
Okay, thank you. Do we have other questions? Brenda, you may have to help me with the questions because I can't see, or Dr. Michaud himself, if you see other questions.
Yes, I see the chat box. So there's one here. Is there any connection between Fabry and macular degeneration? It's a very good question because on paper, there's no real relationship between these two entities. Macular degeneration comes from the fact I showed you the retina, right? So when the light is entering in the eye, goes through the cornea and they kind of converge a little bit, and then goes to the lentic, to the lens itself, the crystalline lens, and then we have the major focus coming, and so the light coming in one ray or focus. The light coming in focus and hit the retina in the center of the retina. And we call this area the macula. Macula, this is a kind of a bowl-shaped area that receives this light focusing in the back of the eye. And this is completely filled with our most prominent good cells, the cones. These are our champion cells who can help us to see. And obviously, as I said, the retina is well nourished because it's a high energy. It's a big computer. You know, if you have computer as big as your house, you know, it will take a lot of energy to run that computer, right? So the retina is just like that. It takes a lot of energy to run the retina. So we have to have a lot of blood vessels. But for any reason, these good cells in the macula become defective and become weak. So they are altered in their metabolism. The first reason is they are not well nourished. Why? Because the natural blood vessels that are there cannot nourish them well. We may think that in the Fabry patients, the accumulation of the blood vessel is responsible for that. Again, it's not true. It doesn't help, but it's not the real cause. The real cause is smoking and blood vessels, other problems like diabetes, cholesterol, blood pressure. Because the blood vessels cannot nourish these cells, they degrade and they die. And because they die, they ask for help. And because these blood vessels cannot nourish them, they generate new blood vessels that try to help, but these new blood vessels are fragile and will create hemorrhage. So we call that the wet part of the macular degeneration. So if you want to prevent macular degeneration, there are one major thing: never smoke. Never, never, never smoke. Smoking is really, really the #1 cause of macular degeneration. The second thing is genetics. Yeah, we can do nothing against our genetics. It's affecting white Caucasian patients most, and it's inherited. If your parents got macular degeneration, you have more chances to have macular degeneration yourself. So smoking, genetics, smoking, what you eat. If you develop diabetes, cholesterol, blood pressure because you have bad habits of eating lipids, cholesterol, all that stuff. If you spend all your day in McDonald's, 3 meals a day and every week, you will probably you'll be probably in trouble. All right, and your blood vessels won't like that. So eating habits can really drive macular degeneration as well. The last thing is exposure to UV light, because some parts of the UV light is damaging the retina. It creates photooxidation, and then the cells degrade because of that with aging. So if you want to prevent macular degeneration, your family has a history of that, don't smoke, eat well. If you have diabetes or blood pressure or cholesterol, make sure that you follow your physician recommendation, take your medication, do exercise, 30 minutes, 1 hour. I know that Fabry patients cannot exercise easily. I know, but the most you can, because it will help. It will help. You can take also omega-3s, good omega-3s, not omega-3 6-9, but the good omega-3s, fish oil at a given dosage. So ask your optometrist about that. And at a given point, he will also recommend some vitamins for the eye that may help. But it's certainly not related to Fabry, but it may affect Fabry as well. It's not because you have Fabry, you will not have macular degeneration. A quarter of patients in North America over 65 years old are affected by macular degeneration. Over 80 years old, it's near 50% of the population that is affected by macular degeneration. It's a very, very, very prevalent disease, and we can prevent that with healthy habits. So I never, okay, I agree. Okay, let's see that. I never knew that the tortoise teeth were outside of the eye. Yeah, I published that. I was the first to publish that. I have many of these microaneurysm and tortoise teeth on my lids and other places. Yes, that can happen everywhere where the substrate accumulate. Certainly, all part of the bodies can be affected. Does Fabry affect the optic nerve? That's a very good question. Yes and no. As I said, the blood spot is enlarged, and I submitted a paper that will be published soon. It showed up that some other parts of the visual field are affected because the oxygen transmission or delivery from the blood vessel in some parts of the optic nerve is not optimal. So some part of the blood of the optic nerve is affected by Fabry, and in the very deep retina, some very sensitive cells are also affected because they are not so well nourished, and this is related to Fabry. So yes, the optic nerve may be at the end affected by Fabry, and not only the blind spot will be enlarged, but it's not a true scotoma. Scotoma means that you don't see in your visual field, but it's probably more a loss of contrast sensitivity that patients are looking at or are affected by. That means that you need more light to see things. You are not comfortable to see under low light condition. Let's say that you're middle of a rural road, middle of the campaign, it's dark, you're not a happy camper, you are not driving safely there, you're not feeling safe, at least because of this and because of the cataract that is present as well. So it may explain a lot of of these symptoms that patients have, not comfortable in under dim illumination, to go to the restaurant when the lights are very dim and you can't almost see the menu, again, you don't like that because your eyes are not built to see under those environments. You need more light. You need more stimulus to help to see. My optic nerve is beginning to show damage to the sheet, which looked like possible glaucoma, but subsequent testing showed it was not glaucoma. Ha! You see exactly what I explained. The loss of oxygen transmission in some parts of the optic nerve look like exactly as glaucoma, but it's not glaucoma. You're right, and it's Fabry, and but it will not affect your vision, and your pressure in the eye is good, so you don't have to take any medication for that. But you're right, it's very, very similar to glaucoma, but it's not glaucoma, it's Fabry. Sunglasses will help, sure. Sunglasses will help, and I recommend a lot of to wear sunglasses, even if it's not so sunny. UV light is there. It's cloudy over there. You have clouds all over the place. You have even more UV light coming
just UV light just destroys eyes
to your eye compared to in full sun. So you need UV protection. You can have UV protection as a filter in your regular glasses. It's transparent. You can ask your doctor about that to put UV filter in your glasses, but you can also benefit from sunglasses because a crystalline lens very soon in the process of Fabry is showing a loss of transparency, and it is linked to light sensitivity, a high light sensitivity. So yes, you may need certainly sunglasses. I wear contacts. They are monthly. I am getting blurry vision if I wear them more than a couple of days. I also have cataracts. What will cause my problem? It's probably eye dryness. Someone who has problems, blurry vision with contact lenses over just a couple of days. Either your prescription is off, which I doubt, but it's probably more eye dryness. And we saw that from my colleague in Birmingham, that they published a series of cases with Fabry affected with severe dry eye. So ask your doctor or optometrist to make a workup on dry and to treat it appropriately. And probably if it's available in your prescription, your go-to lens would be a daily disposable lens, meaning that the lens that you can change and wear just for one day. You change the lens every day. So it would help you a lot. Does Fabry cause your vision to be bad? Yes and no. Yes, if you have cataracts, and the cataract, especially the posterior one, the one that is developing on the back of the crystalline lens, it's right in the middle of the visual axis. It's granular, just like if I put a ton of stones in the middle of a window. So obviously your vision will be reduced, light sensitivity will be high. And this is why, even if the rest of the crystalline lens is clear, this is why most of the ophthalmologists will just, do the surgery. We do the cataract surgery. I was not able to have LASIK due to the dryness of my eyes from Fabry. Yes, Fabry can be linked to eye dryness. And obviously it's not a good idea to get a LASIK if you have dry eye. You have to, but in some cases, we can treat the eye dryness first, have the surgery done, and after that, we follow the patients and we have an ongoing treatment for eye dryness. Eye dryness is a chronic condition. It's not just to put tears in the eye and it's over. No, habitually, eye dryness is chronic again, and it generates inflammation on the surface of the eye. And the inflammation can destruct some cells, can destruct some parts of the cornea. It may affect the vision severely. So we have to take seriously the eye dryness and to treat it appropriately. Most of the time it will take medication on top of artificial tears. Artificial tears or ointments or gels at night is the first line of treatment. But very soon the process, as soon as we see inflammation and we cannot fully control just with lubrication, we will put cortisone, we will put other medication that will help to treat the eye dryness and in ongoing basis. Because if you cease your treatment, your eyes will become dry again, and especially LASIK, it hurts a lot. The surface. I never smoke. No one in the family has it. I eat well and stay out of the sun. Oh, you're an example. You're a very good patient. 75 years old. Thankfully, Fabry was diagnosed by an elderly ophthalmologist when I was 19. Yeah, you were lucky to be diagnosed at that age, but I don't know if you had access to treatment at that time. It's a miracle. Yeah, sure. I used to go to show my worlds to med students at Duke University every rotation where I live. Thank you very much for that, because you inspire a lot of doctors who will look at Fabry with another eye. You know, that's for sure. My students, when they are exposed to Fabry, they don't believe it. You know, they see it. I show them the picture, but when you see a real patient, it's a completely different story. And most interestingly is every of these patients has a different story. I know that you have a different story, every one of you, and you suffered a lot. You went through a lot of things, and as soon as a patient feels that we can't understand their reality, they just open up habitually and they tell us, you know, what their reality was and what it is now. And my students are always astonished about, you know, how hard it was to go through, and how resilient Fabry patients are. You know, really 2 thumbs up, because it's a journey that you have, and they are impressed with that. So if you share your knowledge and your disease with med students and or optometry students, thank you, because you do a great job. You do a great job, and it's not for nothing. You know, you influence the way these practitioners will practice. Try to switch to the daily lenses for people with Fabry. It changed everything. You can throw them away after one day. Yes, daily disposable are probably the safest way to wear contact lenses. You have a perfect lens every day. You do not accumulate deposits. You do not use solutions. Solutions to disinfect contact lenses or to clean contact lenses are chemicals, and to expose your eyes to chemicals over 10, 20, 25 years is not a good thing. So daily disposable lenses are certainly a very good way to go. Yes, my eyes are dry, so it helps to have dailies instead of monthly lenses. Yeah, for sure, no question. Can I increase in eye matter? Can an increase in eye matter be due to Fabry? Also, my eyes appear to have bumps or folds over the whites. Can this be due to Fabry? No. On the white part of the eye, the only thing that Fabry will cause is the vessel tortuosity, as I showed. If you have bumps and folds, 2 things. It's a little bit normal with age to develop that kind of thing, because it's a loosey tissue that reacts also to UV light. And the bumps in the white part of the eye are called pinguicula or pterygium, and they are a direct consequence of UV exposure. So those who are living in the south part of the United States, exposed to a lot of sun during all the year with heavy exposure to UV light, you will develop that. This is why, again, you know, it takes sunglasses, and not sunglasses put, you know, on top of the nose like this, because rays are coming everywhere. Even a regular pair of sunglasses like this, some rays will enter like here from there, and the cornea I mentioned before, the mirror in front of the eye, will act just like a mirror. So if a UV light comes from this side and hit the cornea at the right angle, it will just, you know, be amplified and will end up in the inner white part here. This is why most of the patients have these bumpy nodules or a little cyst in the white part of the eye with age, because we all accumulate some UV lights coming from the side, traveling to the cornea, concentrating and generating these bumps. So these are related to UV exposure and or loosey tissue with time. There are some treatment for that it may generate symptoms of eye dryness though. So I referred patients to ophthalmologists, specific ophthalmologists, to have those folds removed because they were so uncomfortable and the dryness was felt. So after the surgery, it went very, very well. My question is, can you please transmit your knowledge to all other doctors? Yeah, this is what I try with my travels across the country, but with COVID now we are do that remotely, but I did tons of conference on Fabry. My doctor thinks glaucoma, but you were saying that it's not necessarily the case. Is that correct? I would have to look at the details of, you know, when we suspect glaucoma, it's not only the pressure, we will do a scan of the optic nerve and we'll do visual field. And as for visual field, we want to have the same defect showing up in 2 or 3 different visit space, 3 weeks or a month apart. So we have glaucoma damage will be reproducible. If the visual field defect is not reproducible, this is what I see in Fabry patients. It's where the substrate accumulates. Sometimes it's there, sometimes it's there, sometimes it's there. And it's a contrast sensitivity issue instead of a true scotoma or a true loss of visual field. So it can be tricky. And I understand that your doctor can think about glaucoma because it may be very similar, but if you look in the detail at the end, it will make the right diagnosis and treat you accordingly. I'm quite sure that, you know, he's more than capable of that. I think that's about it. I don't see any other question. You can just open your mic if you have one burning question to ask, because if you want to ask something, there's a lot of people in the room that have the desire to ask the same question.
Dr. Michaud, could you stop your screen share at this point?
Yes, sure.
Let me see if it clears up my screen a little bit.
Sorry for that.
No, it's okay. No.
Sorry for that. Yep.
Dr. Michaud?
Yes,
Yeah,
Mr. Steinbreaker. Yeah.
Yeah, I have a growing blind spot in my right eye.
Yep.
50% loss of vision.
Okay.
And the doctors seem, the neurological ophthalmologist thinks it's caused by the optic nerve. Can you address any of that?
Yeah, obviously, if you have a blind spot, but it's certainly related to the optic nerve. Optic nerve is made of millions of fibers. These are very similar to electric wires. So they are all coming from all part of the retina in one spot, and they create the optic nerve. Okay, multiple of bundles of wires there going to the back of the brain, as I said. So the number one issue with the optic nerve is obviously glaucoma. Glaucoma may be because you have too much liquid inside of your eye, so you develop pressure in the eye, and the pressure is for some reason transmitted in the back of the eye and just crush some of the nerves, and you are losing some nerves, so this is why you develop a blind spot. Or your pressure is normal and you have a blood vessel deficiency, because this optic nerve is nourished with blood, right? And in blood vessel, you have pressure. So if the pressure inside of my eye is lower compared to the pressure in the blood vessels in the optic nerve, I will create damage as well. We call that low tension glaucoma. The pressure is normal, but we see damages over there. Habitually, it's linked to cardiovascular disease. And as a Fabry patient, you may develop that for sure. And if your blood circulation is not normal because of Fabry, at the end, it may generate that type of glaucoma. True glaucoma with a lot of pressure in the eye habitually is not related to Fabry. You may have it because with age, 5% of the population at 60 years old will be affected by glaucoma, and they are not all Fabry patients. They can come from everywhere, and the prevalence of glaucoma increase with age because of this equilibrium between blood pressure and the pressure inside of the eye. And we know that at 80 years old, you have more problems with your blood circulation compared to when you were 20. So this is why we see more glaucoma then compared to at 20 or 30 years old. And the third thing is you can have compression of the optic nerve coming from the back. I doubt it would be your case because it may be a cyst. It may be, sometimes we see that very rarely, but we see a tumor, we see something, but it compresses the optic nerve and create that scotoma. But certainly when we see those, blind spots enlarging in one part of the visual field, and we don't see nothing obvious on the back of the eye, we may see some alteration of the optic nerve, but we have to go a little bit further than that. What caused this? They will probably prescribe scans, MRIs. They will prescribe imagery testing, scans of the optic nerve to evaluate where it is coming from. And when they'll find the source, they will treat it, and or one of the only way to limit the damage is to reduce the intraocular pressure. So to protect the optic nerve. So they may prescribe drops that will just lower the pressure and then protect the optic nerve, regardless of the cause. It may end up that way. Some surgeries can be done to protect the optic nerve and to lower they can open some channels with laser. They can do it. So depending on the nature of the disease that you have on the optic nerve, there's certainly one treatment for that. But Fabry may be one factor. It's not the only cause, but it may be one factor because it affects the blood vessels, right? And most of the aging problems with the eye are coming from blood vessel or blood circulation that is impaired or weakened.
Thank you, doctor.
Pleasure. Other questions?
All right. Well, thank you all so much. Thank you, Dr. Michaud, for the great presentation and for answering all those questions, great questions. So we're very happy to have you with us here tonight. We really appreciate it.
My pleasure.
And the next thing that we'll do tonight is I would normally show an announcement slide where we highlight some of our sponsors, but I'm having technical difficulty again, and I don't know whether I can share my screen. So before we do that, in case we lose you prematurely, we'll go ahead and do the prize drawing for tonight. So if everyone can put EYES, E-Y-E-S, in the chat box, all of the primary attendees, people with Fabry family members and caregivers, in the chat box. And then Brenda will, Brenda, are you with me?
I am here, Jerry.
All right. Because I have a limited view of what's going on out there with something's going on with my computer. So while those are coming in, I'm going to attempt to share my slides. If you lose me, would you please announce the winner and say goodnight for me?
I can do that.
But thank you, as always, thank you all for coming in case I'm unable to share my screen and I lose you when I try. So. Well, I can't even select the share screen button with you. So we'll skip that part of tonight's presentation and not do the announcements. But if you go back to any of the recent previous presentations, meetings, and look at those recordings, you'll see the announcement slide. It hasn't changed in a little while, so you'll see the ways that you can connect with the different industry partners if you're interested in knowing something about the various treatments and the various clinical trials that all of the industry partners are participating in or providing. And on our website, as you know, we have a section where you can find resources from all the industry partners of what they think is valuable information for the Fabry community. So if you haven't seen that before, just go into the registration website and select on the archives recordings tab, and you can see the recordings there and select any one of those and find that same announcement slide that we provide each time. So with that, Brenda is putting all of your numbers that were associated with your answer from the chat box into her prize drawing machine, and she's going to give us a winner any moment. And as you know, each time we have a meeting, we do a $100 Amazon gift card prize for participation, just to make it a little bit excited, a little bit more exciting. I don't think with COVID still beating us up so much, we don't get as much excitement as we need to. So this probably really doesn't help, but it's still fun to do anyway. So we'll give Brenda just another minute.
Yeah, I actually do have a winner. Everybody was on the ball with putting their I in the chat. And the winner for tonight is Carol Treadwell.
Say the name one more time, Brenda.
Carol Treadwell.
All right, great. Well, congratulations, and we'll get a Amazon gift card up to you by email. And then thanks again, everyone, Dr. Michaud and everyone for attending, and we will see you next time. Have a good evening.